A surgical cricothyroidotomy is indicated for the patient that you cannot intubate and you cannot oxygenate. So examples of that would be a foreign body airway obstruction, obstruction from trauma or swelling such as anaphylaxis, a difficult airway that you've had a failed intubation for and you cannot oxygenate in any other way. So it's kind of your last ditch effort to get oxygen into this patient. So it needs to be done reasonably quickly, but you've got to get a few things ready first. PPE, glasses and gloves. So I've got a scalpel here ready and a sharp container for it to go into. I've got my bougie. I've got a size 6 tube and I've checked the cuff. I've also got a size 5 just in case I get in there and realise there's not a lot of space. I've got my bag mask all ready and set up. I've got my capnography plugged in, my filter, and I've also got some gauze here to try and help mop up the mess, if there is any, and a way to secure the tube. So some options are tape. Some people have mentioned using a paediatric Thomas tube holder or a tube tie, which I don't have, which I think I would probably go for. So we're going to have a quick look at our patient and assess how difficult their surgical cric might be. And you can use this using SMART or short. So I use SMART. So we're looking at the area where we're going to do the procedure and looking, have they got any evidence of past surgery in that area, scars, masses, which is M. A is for access or anatomy. So what does their anatomy look like in terms of the shape of their neck, lots of fatty tissue around it, how long is their neck, can I palpate some landmarks, and am I able to get access to the patient to do the procedure? Radiation, which could be, do we know if they've had radiation therapy in that area before, which can change the anatomy and the structure, or do they have burns in the area, which can help, or it can hinder finding the right landmarks, or any tumours, which is kind of same as masses. So have they got anything in the area which changes the anatomy, which makes the landmarks harder to find? So once you've gone through that and you've decided you're going to go ahead, you want to try and keep everything as sterile as you can. So we've got it here on a nice sterile sheet. We're going to clean the area with whatever we've got. And we've got hopefully sterile gloves, otherwise give things a bit of a clean. So we're going to palpate, looking for the laryngeal prominences, the laryngeal horns, and then between that with a thumb, feeling for where the cricothyroid membrane is. So in between in the male and where the Adam's apple is, just below the greatest prominence. So once we've found that, I'm going to take our scalpel and stabilising the area using a bit of skin traction. I'm going to make a 4 to 5 centimetre vertical incision until we have made it through so we can see the cricothyroid membrane. So once we can see the membrane and we're happy we're in the right spot, we can palpate if we need to. I'm going to take the sharp blade and pierce the membrane on the side, and we can twist it to the bottom to make an opening. And then without losing our spot, we're going to try and get our little finger, get rid of that here, get our little finger and just open it up slightly to get into the space. With the bougie, I'm going to sneak it in beside where the finger is, into the right hole. You may feel the cartilage kind of rings as you go down. An airway assistant would be awesome, but if you don't have one, keep hold of that bougie and railroad your tube over top as best you can. And as you go through the opening, pushing it down, you want to get the cuff through through the gap. This one's a little on the sticky side. And 1 or 2 of the black lines through the gap would be ideal also. So I'm going to inflate the cuff first and remove the syringe before I remove the bougie. Again, if I have an assistant, would be great. Attach, try not to let it get dislodged. And I'm going to look for some chest rise and fall to see if it's even. And I've also got my capnography plugged in, so I'm going to have a look over at my monitor and check what that's doing. So once I'm happy initially that I've got it in a good spot, I want to try and secure it. So I'm going to do a bit of a quick bit of tape just to give it an initial securing. So whichever you use, you want to make sure you don't have too tight that you are cutting off blood flow up to the brain. So once you've got it secured, you can give it a bit of a clean up because it's probably going to be a little bit messy. You can cover it if you want to, but you shouldn't need to. Hopefully it's nice and clean. And then double check that you've got good air entry, having a listen on both sides, and having a look at your capnography waveform and your pulse oximetry to see if you've got an increase or reading from those, and then ventilate them as appropriate. Take to hospital.